coming today. Try to kick off the new year on a good note. And I hope everybody had a nice holiday and a happy new year. And come back, recharge, and put 2020 behind us. And just hopefully keep looking up. All right, well, first I want to go to the agenda. And we're going to start with brief introduction. I know we have some new people here today. Then we're going to appoint a secretary to record the meeting minute. And then we're going to review and approve the meeting minutes from our last meeting, which was on December 2nd. And then we will go ahead and allow Anis and Lisa to go down. Somebody playing music?
Sounds like an airplane.
Or Mars.
That's all right. I think we got it under control. All right. Back to where I was. Okay. After we review the meeting minutes, we'll introduce Anita from the Rhode Island Executive Office of Health and Human Services. Welcome, both of you. And then we'll move on to progress update on the Healthcare Committee and the HSTP projects. And I know Dr. Marie Lynn might be joining later in the meeting to give a quick update as well. And then we'll open up to public comment for everybody and schedule a future meeting. And then we'll wrap up the meeting. All right. Well, since we have more people here today, I wanted to make sure we introduce everybody. I'll start off. I'm Brett Hayes. I'm a commissioner on the board for the Deaf and Hard of Hearing. I'm also the chairperson for the Healthcare Committee. And I want to thank you all for joining today, especially late afternoon. And we'll just kind of get started and introduce others on this committee. We can start with Caroline.
Hi, I'm Caroline Obrecht. I'm a commissioner, and I'm happy to see everybody here today and give a special congratulations to the newly married Brett.
Thank you. Yeah, Mr. Hayes, it sounds old. It sounds like my grandparent. Well, thank you. I appreciate that.
Hey, Brett, I missed what you said.
Sounded
What was
like
that last comment. You sound like your grandpa?
No, I've heard a lot of congratulations, Mr. and Mrs. Hayes, and it just reminds me of my grandparents. Yeah. Anyway, well, thank you. I really appreciate that. Welcome, Caroline. Next, I think Christine is still on the camera. So,
Hi. Thanks, Brett. Good afternoon. Congratulations also to Mr. and Mrs. Hayes. And welcome, Anis and Lisa. I look forward to learning more about the data ecosystem under EOHHS and other data opportunities for us under the Healthcare System Transformation Project under RICDHH. And welcome, everyone. Happy New Year. Good to see you.
thank you,
By the way,
Christine.
I'm the project manager for the Healthcare System Transformation Project under RICDHH.
One of many hats to wear.
Yes.
Thank you. Alex, would you like
Hey
to?
everyone. Yep, name's Alex LaFerrier. I serve as the outreach coordinator on the HSTP project. Happy to be here.
Great, thanks for joining today. I think I see Michelle is here today. If you're able to.
Hi, yeah, I'm Michelle Zylan from the Office of Healthy Aging. I'm the Deputy Director.
Great, thank you for joining today. And then I'm just going to check and see if anybody else on the committee is here. And if I didn't name you yet, feel free to speak up. But I think that might be it. And then we have Ernest.
Yes. Hello, everybody. And congratulations, Brett, on your marriage. Happy birthday, Christine West, also. My name is
Oh.
Ernest Covington III, and I'm the Executive Director of the Rhode Island Commission on the Deaf and Hard of Hearing. And Happy New Year, everybody. I'm excited about this committee. I'm looking forward to this meeting and future meetings. Thank you.
Cat out of the bag. Happy birthday, Christine.
Thank you. Thank you. And I'm going to let another cat out of the bag and get my redemption with Ernest. It's your birthday tomorrow, I believe, January 13th. So early happy birthday to you.
Of course. Well, look at that. Happy birthday.
Thank you. Thank you.
Happy birthday. Great, thank you. And then we have, I see Mike here today.
Yep. Hi, everybody. Hi there, Brett, and everyone else on the committee. Good to see everyone. Happy New Year. I'm with the Commission on the Deaf and Hard of Hearing, and I work as the Emergency Public Communication Access Coordinator. I've been working on COVID and making sure that the COVID information has been spread to the deaf and hard of hearing community in Rhode Island. This committee is really important to me. And so I told myself this year I'd make it to every meeting because healthcare and emergency communications are so intimately tied. And we need to work side by side. And I'm very happy to hear the results of HSTP, the survey. I believe it may be ready. I believe you'll be talking about it today. And very nice to meet the two of you from EOHHS, Anise and Lisa. And this is Ernest. Just a very quick timeout. If possible, if folks wouldn't mind just turning off their cameras so that we only have 4 people on screen at once, that makes it easier for those of us using the interpreter to see.
Thank you. You guys are all able to do, myself and Carol, who are interpreting right now? All right.
Their cameras are closed.
Yeah, that's true. Yeah, all right.
You can type it in the chat if you'd like, or if you have a question just to pop up.
Okay. All right, that sounds good. Thanks, Mike. And then I believe I didn't mean to pass, but I think Lindsay is on the line as well. So if you want to introduce yourself and say hi, you can turn on the camera if you want to. If not, we can move on. Hi.
There you
Hi.
go.
Everyone, Happy New Year. It's good to see some friendly faces. My name is Lindsay Conway. I'm just coming off of working on HSTP with Christine, Alex, and Thomas. And I'm currently working as community liaison for the commission, supporting Pam Zellner and Mike Baer.
Great, thank you for coming today. I think who just popped up?
Marie
Dr.
Lynn.
Marie Lynch. Oh, yep. Hi, how are you? We're just introducing everybody today just to make sure letting each other know who's here and where you're from.
Sure. My name's Marie Lynch. I am a professor of special education at Rhode Island College, and I have been working closely with the commission, especially Christine and Ernest, to bring a public health interpreter program to Rhode Island College.
Great, thank you, Dr. Lynch.
Sure.
All right, and then the Lucy Cruz that is here. You want to introduce yourself? No. All right. Well, welcome anyway. And then we can move over to introducing our 2 guests here today, Lisa C. and Anise Correa Gabriel, if I pronounced that correctly. I can start with Anise, if you want to quickly just introduce yourself.
Sure. Is it helpful to have the video on?
Yeah, if you want to.
Okay. Great. I'm Anise Correa Gable. I am Deputy Director at the Executive Office of Health and Human Services. I work with Lisa Stay, who's on this call, on the ecosystem team. And we're really excited to get a chance to speak with everyone today to share more about what the ecosystem could potentially offer and learn more about the priorities for this healthcare committee. So thank you for having us.
Awesome. Thank you for coming today. I really appreciate you taking time out of your day.
Of course.
And then Rita? how are you?
Yes, good, thank you. Just to reiterate what Anise shared, thank you for having us. We're excited to join you, and the purpose of today's conversation is to provide an overview of what the data ecosystem is, and to explore with you some potential opportunities for collaboration. So more to come.
Awesome. Looking forward to it. Thank you. I think that covers everybody who's in the room today. And we can move on to the next step of the agenda, which is to appoint a secretary to record the meeting minute. Do we have any volunteers that want to be the secretary today? Going once, going twice, and I'm happy to do it again. I'll just get the transcript from Bethany, and I'll just try to make notes as we go along. And if there's any presentation material that's allowed to be shared, I'd be more than happy to get it and include it in our meeting minute, or just summarize it if we don't want to include in the meeting minute. All right, we can move on to the next part. If Bethany, you can pull up the December 2nd meeting minute. So this is a draft copy, and we just want to review it one more time before we approve it and submit it to the state for record keeping. So the top half is pretty much self-explanatory. It's just all the key information about the meeting. If we can just check to make sure I have you in the right bucket of whether you attended or did not attend. But I looked back at the recorded meeting on June, and I think I captured everybody. And then the first 3 bullet points, again, also pretty straightforward. We really spent a lot of time talking about project update and wrapped up before the end of 2020. We talked about the Gallaudet surveys, the completed, they were targeted at the time to be completed by mid-December. And I put in the information that was shared. And then I also included update about where we stood on the overall projects and some of the open items they had been working on before they were finishing up the year. And then we kind of moved into what some of our key objectives were for calendar year 2021. Again, it's very brief, summarized bullet point. If there's anything in the meeting minute that you want me to add, please let me know. All right. Well, I'll take the challenge as it was pretty good. Everybody's comfortable with it. And I will review it one more time for any spelling errors, and then I will submit it to Pam at the office, and she will happily submit it to the state for us.
Brett, I do have one question. I don't,
Yes.
this is Carolyn speaking. I don't believe that Thomas Darden was at that meeting. I think he'd already left for his new job, I think.
Oh, okay. I'll write that down. Looks like I need a new notepad.
We're going to switch interpreters, Brett.
Okay, thank you. Hi, Tina, how are you? All right, thanks for joining. I'm gonna make that update in my note, and I'll update it after the meeting and then submit the meeting minute to Pam Joner. All right, moving on. The next step of the meeting agenda is we want to give time to Anit and Lisa to introduce themselves, talk more about the agency they work with, and their presentation on the ecosystem project they've been working on. So Anit and Lisa, how do you prefer to do that? Do you want to share your presentation, or do you want to just share your camera?
Yeah, I think I'm happy to present, Lisa, if that's okay with you. Okay.
Yes, that sounds great.
Okay.
Okay.
Is it helpful to keep our videos on or easier for them to be off?
Yeah, I can turn my video off, but I'm not sure, Bethany, are we able to share the screen and Anit be able to be on the screen, or would she have to be off screen so Tina can be on the screen?
So whoever is presenting, if they could just have their video open with the interpreter if we are screen sharing. And I believe I would need to give you the ability. I'll set that up for you to screen share. So give me just half a second.
Okay, no rush. Thank you.
Great. So, Anise, would it make sense for you to share your video as you are the primary presenter? And I'll turn mine off in the interim unless something pops up.
Sounds great.
All right.
So are you able to share right now, Anise?
It still says disabled.
Okay, I will, give me 1 second. Okay, so for right now, I've made it so that you are one of the co-hosts, so you should be able to share your screen now. There you
Awesome. Yay.
And Carmen, unless you're presenting, if you wouldn't mind shutting your video down for right now. Perfect, thank you.
Okay. Well, thank you again so much for having us. We are really excited to share a little bit about what the data ecosystem is, and we can provide any additional context as we go. Please feel free, both Lisa and everyone else, to interrupt if there are questions or clarifying points or just a good stopping point for discussion. Okay, so a little bit of information about what the ecosystem is. Like we mentioned, we're from the Executive Office of Health and Human Services, and we sit specifically in an office that works on data and analytics. The ecosystem itself is what we call our integrated data system. So as it says here, it's an analytic system that links data at the person and family level across many state agencies. The goal of this is really to be able to offer a more complex view with the data that we have across agencies, to be able to speak better to this concept that people are not simply slices of data, that they're whole human beings living in connected families and rooted in communities, and having an integrated data system that reflects the data across multiple agencies is truly valuable, not only to EOHHS, but also to other state agencies and external stakeholders. The primary, so we have these internal pillars, resources, the data extracts, custom reports, which is something we could explore with this group, and interactive dashboards. The people that work on this for the most part are our analysts on the ecosystem team, but we'll also partner with analysts at other agencies or external researchers. And the process pillar is really about building a culture around insights that we can gather from integrated data and having those serve as the basis for decision making for our agency leadership. The ultimate goal is really a well-designed, well-stewarded programs that serve our state stakeholders really well and high-performing agencies. Lisa, anything to add here or in the previous slide?
No, not at all. I'll just reiterate that, our main focus here is we want to support data-driven decision-making. And, just to add a little bit more depth, which Anise will also provide additional details on shortly, when we talk about cross-agency data, what that means is we're not just talking about clinical data, but also administrative data from programs that are state-sponsored and rolled out with the intent of supporting all Rhode Islanders.
Awesome, thanks, Lisa.
Of course.
Hey, before we move on, I just wanted to ask, are we able to see the interpreter? Is everybody able to see the interpreter as well? You can put it in the chat box if you want. Okay. All right, go far. People can see it, so you may proceed. Thank you.
Okay. Here we go. So just a little bit, I think that this is helpful. It's a little nitty gritty here, but this is how we govern ourselves within the ecosystem. So there's a few different layers that we'll discuss. At the highest level, we have an executive board, which really ensures alignment with state priorities, recommends and supports large projects that we pursue, and helps us determine how we sustain ourselves both financially, but also as an asset to the state. Our leadership at the time are Secretary Jones and Commissioner Ganem, who's the vice chair. And membership includes leadership across all the agencies whose data we hold. So those are the agencies that work directly with EOHHS or are part of our umbrella, as well as DLT. We have representation from the governor's office, IT, and as well as policy and legal at EOHHS. And that group meets quarterly. This data stewards group are the people who are truly subject matter experts and tend to be much closer to the data. So we meet with this group on a monthly basis. And within the context of those meetings, we will discuss the projects that come up. So we'll also review kind of what a project proposal will look like and that have the different layers that it'll go through, but that will definitely interact heavily with the data stewards group that Lisa and I both help to run on a monthly basis. And then the day-to-day work is the ecosystem team. So we're run by Kim Paul, who's our director, deputy director, Lisa is our program manager, and we have both back-end staff who match all of our data across systems and front-end staff who run most of our analyses. Are there any questions here?
Hi, Anise. I had a question
Yeah.
about the data providers. How does one become a data provider? Are there certain agencies that are identified as becoming providers, or is that something that agencies can opt into to share data with you?
Yeah, that's a great question. So at the moment, this really gets into the details of it. So the agencies that EOHHS oversees and kind of the natural first step of starting the ecosystem started with Department of Health, Medicaid, BHDDH, DCYF, and DHS. And then we also expanded to include many DLT, a lot of wages, and more recently have brought in TDI, TCI, and UI claims. And one kind of an outlier is that we have a partnership with the Coalition for the Homeless, where we have homeless management information system data that have come into the ecosystem. So to answer your question, there is a process that I can actually go here. Or, oh yeah, this is the right one. Okay, so when we initiate partnership with a new agency, we'll sign an interagency memorandum of understanding. And that really governs the relationship between the ecosystem and that external agency. And then once we establish that partnership, it's possible to bring in the data to link them to the rest of the data in the ecosystem, and then to propose projects that would be governed by the data stewards, if that's clear.
Yes, it is.
Okay.
How long does that, and what does that process entail? And how long does that typically entail to have that agreement in place? I'm just curious.
Lisa is like our go-to person for this. Like, so it really does depend on the project and how many data stewards. And so if we had a project, for example, with 10 different data stewards, we might expect that sign-off process to take much longer. I think at fastest, it's been about a month to 6 weeks. And at longest, I don't know, Lisa, what's our longest one?
Well, from external agencies, it can be longer. And I think at this point, it's probably worth taking a step back and teasing out the two parts of your question. And that will kind of help inform the time. So the first part of your question I heard was, how do we go about partnering with different agencies and even bringing their data set in? That is generally a bi-directional conversation that is typically led by a use case that's been defined or identified. Take, for example, a group will come to us saying, this is what we think is a priority area. There's big support for it across the state from the governor's office, et cetera. We already work in partnership and we have this data. Now, what we really want to do is break down these data silos and marry it all together so that we get a much more comprehensive picture of an individual. What this means is it's going to be their clinical needs, their financial needs, aspects about social determinants of health, right? Like housing insecurity, a health equity lens. And once there's a really strong use case for that, then we bring together our legal teams to say, look, we all have the same intent here, which is to be really, really careful and respectful stewards of the data that we have at our disposal. This means that we always need to do things with an eye towards protecting the rights and the privacy of the individuals who that data represents. And so what we do have established is a series of legal documents. As Anise mentioned, one of them is the, thank you, that IMOU. And throughout this conversation, we're gonna throw a lot of acronyms out there. Please stop us at any time, because we sometimes forget that this isn't common language anymore. But an interagency memorandum of understanding essentially lays out at a very high level what the data contributor and what ELHHS, or the Executive Office of Health and Human Services, it's what we call the rules of the sandbox. What are we willing to share? What are we not willing to share? How will that data be shared? How will the security be governed? How will its release be governed? Once we have it established and all the legal contracts are in place, then we talk about the technical side of things, which is we will work with each data agency submitter to help them understand their data. Some agencies know more than others, meaning some will say, like, here's a data dictionary. I could tell you right away what the different fields are, what they mean. Not every agency is there, so we do work in hand with them. And then what we work towards in its ideal state is that we will get a new kind of extract or a new batch of data from the agency on a regular basis. And we will build out standard processes for taking that data in on a standing basis and efficiently and in a standardized way, integrating it in. And then what you have at the end of that product is what we think of as the data ecosystem. And what Anise is showing here on the screen is our general process then. For example, IMOUs are going to be signed at like the very high leadership level. Data sharing agreements are kind of the second layer down, and that really governs the types of identifiers that are going to be shared. and how data will be de-identified. And then it kind of puts in place a structure of like day-to-day management. Now, when there is someone who comes to us saying, this is a research question I have, I think your data is going to help me answer that. What we ask them to do is they go ahead and submit a form that's actually not captured on here, but it's called a data license request. And this is what we're looking at here. A data license request very much mirrors what is familiar for any sort of like project proposal or an IRB proposal. What that lays out is at a high level, what's my research question? Why does it matter? What are the data sets and data elements that I would like to access? What's my analytic approach? And then how I plan to, what are your deliverables and how do you plan to disseminate? And the primary audience for this are these designated data stewards of each data set. So as an ecosystem, we help facilitate the exchange of data, but we respect that every agency, every submitter owns their own data and knows it best. So what these data stewards do is they know their data best. So, there's two parts to why we have a data license request. One, they can work in partnership with the requester to say like, that's a really good research question. Have you thought about finessing it in this way? Or you know what, this is the data we have that would enable you to do this, and here are the limitations. The other piece of that too is that they really want to see that the data, the research is worthwhile. And two, we always respect minimum use. We never want to share or give out more data than is truly necessary to help protect confidentiality. So that's the general process. Once they sign off, and that's the process that Anise mentioned in terms of release, best case scenario, it takes a month. Worst case scenario, it takes a little bit more, back and forth with legal and such. Once that's signed, we execute what's called then a data use license, a DUL. And that essentially just puts into parameters saying, these are the elements you're allowed to use now, and these are the security parameters that you have to abide by. You have to store things very securely per these terms. If you have cell sizes that are smaller than 15, you have to suppress that to protect, we never want, Rhode Island's a small place, so you never want anyone to back into finding out identities. And it also will just lay out, at the end of the project period, this is how the data should be destroyed. So that's the general overview. Are there any questions? That was very detailed.
That was perfect. Thank you.
Okay, good.
Thanks, Lisa.
Of course.
Okay, so I think that was super helpful, Lisa. I think it's good to
I'm sorry, Anise. I think Ernest has a question.
Oh yeah, sure.
I can't see. Your microphone is off.
Yes.
Sorry.
Sorry. So I think it's great about this data process and the partnering. I think that's really great. But I wanted to ask you a question related to COVID and people with disabilities. And the reason I'm asking is because have you already envisioned, people with disabilities and the COVID, their research? There's been no statistics and data related to COVID with them, and to see if they're high risk with COVID. A lot of people with disabilities have had high death rates from COVID, and now we have no data. We had data for all people, but we want to be able to focus on just people with disabilities only, like deaf, blind, multi-deaf, the whole thing. We want to know where the data is for disabled people. And that's why we've been struggling with information and struggling to get information out of vaccines, because we have no link for that, no information for that. Do you plan to think about including people with disabilities in the COVID issues? Because we've heard that people with disabilities have been highly impacted by this COVID, and we're wondering where that data is. And so I'm wondering if you're considering starting a program like that. That's just a question I had.
Yeah, Oh, sorry. I don't know if you can hear my dog, but he's not happy. That's a great question. Thank you. So we at the ecosystem team are not currently pursuing COVID questions that pertain to that population. That said, I think that the data that we have within the ecosystem might be able to answer some of the questions that you have. Or better yet, try to think through who are the people who are analyzing the COVID data and see if there's a willingness and ability to slice by disability type. I know for the data that exists in the ecosystem that are COVID specific, we don't currently capture who is disabled for the data that we are able to see, which is not to say that that doesn't exist within the Department of Health data, but the view that we get doesn't currently capture that. That said, there are ways to identify a population with disabilities within our data and then to cross-reference it with COVID data. So if we were to pursue something like that, or if that were something that was of interest to this group, we would put together that data license request and try to get the necessary data stewards to sign off on that project. And hypothetically, that could be something that could happen as with analysts at through the commission. But I don't know if that is exactly, Ernest, what you were hoping for, or if it sounds like perhaps you're also hoping for more information from the state with that breakout for COVID data. Is that right?
Hang on, I just have to get Ernest on my screen. There he is. Okay. Yes. There are different disability organizations like the Governor's Commission on Disabilities, our organization and so forth. And we need to know how our people are being impacted. I would love to partner and discuss and give information that we have. If we could do a project together, I'd be really interested in it. And because I'm hearing complaints from folks with disabilities and they're wanting to know, where is the data? Where is the evidence that people with disabilities are maybe more vulnerable? And right now they're complaining that they feel neglected. And I'd really like to talk to directors of agencies and have a deeper discussion with them based on data.
That makes sense. So perhaps a good follow-up from this conversation will be to look at what would a data license request for that specific cut of data, both looking at COVID and those with disabilities, and to see if we were able to move forward with that request. That's certainly a possibility. And I don't know if Christine or others had other things that were of interest that we could discuss at this point, or we can always go deeper into the details at a later time.
Hi, yes, thank you, Anise. Yeah, there's actually plenty more data that I would love to request on behalf of the Healthcare System Transformation Project. We can certainly talk about that in more detail, perhaps at a separate meeting. Perhaps Ernest and Mike Bear and myself could possibly meet with you at a separate time, and we can talk about some of the requests that each of us have in regards to data. I know for HSTP, we have 3 goals as a part of our project. And the first goal is data collection. And that includes the development and dissemination of 2 different surveys, one for the deaf and hard of hearing community specifically in regards to health outcomes, barriers to care, barriers to access, as well as costs of care. And so that information is vital for us in terms of informing future next steps, future programming, future legislation, future policy. So we would love to have a more lengthy discussion with you about that. Another request that we have, and I'm not sure if this falls under your purview or not, but certainly being able to have some kind of capacity to focus on transitions of care for the deaf and hard of hearing community. For those folks who are deaf and are American Sign Language users and require interpreters for healthcare appointments, they may make a request with their physician And there's a lot of advocacy, self-advocacy that goes into that process of trying to get an interpreter. And then once they move on to a hospital or a specialist or some other facility where they're seeking healthcare, that information doesn't follow them where they need an interpreter at those other junctures in their journey. And so they have to self-advocate at each juncture. And that can be tiresome and it can be frustrating. And so if there's any way for that information to somehow follow them, that can be a huge transformation in the system for them. And that would allow them to be able to have greater access to those healthcare professionals and certainly make their journey a lot less frustrating along the way. And certainly having access to demographic data when it comes to healthcare in the deaf and hard of hearing community. And I just do want to reiterate what Ernest said. Oftentimes, deaf individuals, specifically the deaf and hard of hearing community, their data isn't necessarily captured. If data is captured, it's usually as a disability group as a whole, if that's even captured. And so that more granular data is not there for the deaf community to be able to access typically, or we haven't up until this point, and we're hoping that we can. And that information is vital for us to be able to go to the legislature and advocate for funding or for programs or improvements in the system. And we haven't been able to do that. In addition to that, well, I could go on and on and on, so I'll stop there and save that for another meeting, but yeah.
Okay, I think that's incredibly helpful. And Lisa, I'll let you share out in just a second. I think some good and helpful follow-ups for us will be to see how the deaf and hard of hearing community is represented in a couple particular data sets here that I'm thinking of. So within Medicaid claims data, I'd like to do a little bit more digging and see what we have that would be relevant for this group. And it sounds like another data set of particular interest would be the COVID data that we're pulling in from the Department of Health. I think we need a little bit more follow-up to know what data exists there to see if we would be able to help pursue these particular questions.
I agree with that. The additional pieces I would pull in here is, at the heart of things, we hear your frustrations. The questions we can ask are limited by the data that we have and the insights that it provides. So as Anise mentioned, I think a really important first piece is to take stock of what we have. If there are limitations, and the follow-up discussion we would have is there any other supplemental data that you can help us connect with or bring to the table, which would allow us to kind of flesh out our ability to identify the specific population of interest. With that said, there is also a quite important caveat and limitation that I want to put forth, which is a core component of how the ecosystem is set up right now is that we are not allowed to release any identifiers. So Christine, to your point about having records follow folks, we would not be in a position where we can release any information that would identify individuals. So just be aware of that. Where this is really helpful is we can definitely provide aggregate numbers and counts to help you understand a specific population and their demographic features, but we could not release anything on a person by person level.
Thank you, Lisa. I appreciate that clarification. Thank you.
Okay, so I think there's a lot of detail here about the data sets that we currently hold. For awareness, we are also currently working with Department of Labor and Training on additional workers' comp data, as well as bringing in data on who's participated in their REALS program, so Real Pathways, Real Skills, and Real Jobs. On a project-by-project basis, we will also bring in data on LTSS, long-term services and supports, the PDMP, there is prescription drug monitoring program, data, and we'll also occasionally have projects that we have engaged with the Department of Education, and we'll work directly with their data governance board to examine their data. So this is really the world of what we have right now. And as Lisa mentioned, if it's possible to supplement with additional data on particular populations, we're happy to work with agencies to do that. Okay. I think we covered a lot of what's here, but just a quick overview again is that when we have a data license request, there are several layers of folks who will engage in that process. So at the very beginning, the requester puts together that document that Lisa had described that really puts forth the objectives of the project. At that point, the ecosystem team, so Lisa, myself, and others will engage directly with the requester to make sure that everything being requested aligns with what we have, and help put this document together for review by the data stewards group. And the data stewards group will, as a whole, review it and individually sign off for anyone whose data is represented in that data license request. And then after legal review, we have data stewards sign off, and then that results in the data use license, which grants access to those data. In the past, this is an example of the different types of projects that we've worked on the ecosystem team. So in some cases, we'll really gear towards folks who are at agencies who are ready to access our data and don't really need too much assistance from the ecosystem team to be able to analyze it. So we'll work with getting data from other agencies to the agencies that are requesting it. We also have worked a little bit on vendor management tools. We have a couple of partnerships with some external researchers. So Brown University Policy Lab, as well as the Boston Federal Reserve, have worked with our data. And then we'll also do, the ecosystem team ourselves will take on these centralized statewide analyses. So in the past, we've looked at broadly what's happening with child maltreatment and how we can better prevent it as a state, medication-assisted treatment enrollment study, and recently worked closely with Department of Health and others on compiling analyses of what's been going on across the state since December 2019 with an uptick in overdose deaths. And this is an overview of how our data flows throughout the system. We bring it in and there's a person identifier. So we are able to link across all the data sets with that identifier and then use that to come to develop our analyses and present findings. A lot of the time for our internal stakeholders, we'll develop dashboards that we are interfaced with through a Power BI data dashboard. I don't know if that would be the case for this, if we were to engage with this particular group, but that would be an option that we could discuss. And so kind of next step, so we are focused on holistic support of Medicaid enrollees. Medicaid enrollees make up a large number of the people, Rhode Islanders, who are represented in the ecosystem. And our goal ultimately is being a statewide hub for analytic services to improve agency operations, service, and stewardship. We have a few appendix slides, but I think I'll pause here and see if there's any additional follow-up from the group or questions, and we can clarify what are the best next steps.
Thank you, Anita. I really appreciate that, and Rita too. Did anybody have any other question for both Anise and Lisa.
I actually have one. So it's Medicaid enrollees. It's not people with private insurance or Medicare enrollees. Is that correct?
So we actually do have a separate, I didn't go into this too much, but there's an all-payer claims database that would include privately insured Rhode Islanders as well as Medicare. And a very important caveat is that the all-payer claims database does not link to the rest of our data. We're not legally allowed to do that. So the Medicaid data is linkable. And a lot of our claims analysis will be done primarily on Medicaid claims.
And the Medicare is not allowable because that's a federal program. Is that why?
Lisa, do you happen to know that?
Yes. So how there is part of what's called an all-payer claims database. Many states do have them, and the governance guidelines for each set can differ from state to state. It's legislatively driven. So in the state of Rhode Island, Medicaid serves as the backbone of the ecosystem. We actually secured funding to build it out for Medicaid and then was able to stack on additional data sets from across different state agencies, which is why we have full purview into it. However, in terms of Medicare, we only get that as a submission to the all-payer claims database, which is why specifically in Rhode Island right now, it is still seen as a separate standalone data set that cannot be linked to other administrative data. Was that a clear enough response for you?
Yes, although I feel like I'm learning yet another language today, but thank you.
We're teaching you how the sausage is made, which might be a little bit too much. So feel free to stop me.
Yeah, like little mini sausages, please. Okay, thank you.
Christine, did you have a question?
Yeah, I just had two quick questions. Lisa and Anise, I'm not sure if this again is under your purview, but I was curious about like a statewide e-referral system and also the statewide health information technology strategic roadmap. Does that fall under your purview, or is that considered something completely separate under some other folks?
It is something separate. To your second point there, high tech, right? The health information technology. I do know that there is a statewide project ongoing in that space, and Marty Rosenberg, if you're familiar with her name, is a key leader in that initiative. As for e-consults, you know, the ecosystem team really is outside the purview of real clinical data. So, you know, health information exchange or EMR data, that is going to be a separate entity altogether.
Great, thank you. And thank you for your presentation.
Of course.
Anyone else have any question? I do have one question. Does this database in any way maintain data around accommodation from the deaf and hard of hearing community, whether it's in the court system, whether it's in the doctor's office or hospital system?
Brett, could you explain a little bit more of what you mean by accommodation data?
Like for deaf and hard of hearing, when they request interpreters, like do you also keep data for when there's individuals who use English as a second language and they request foreign language interpreters in the hospitals and court system? Do you also maintain that data for deaf and hard of hearing people who request sign language interpreters, or if they request video interpreting and things of that nature?
I think the main way that, or Lisa, I'm curious to see if your thought differs, but I think the main way we would aspire to look at that is through the Medicaid claims data. I don't know though if we are capturing it.
That's correct. I agree. And just remember, at the heart of it, claims data is billing data. So it's not going to be 100% accurate source of everything you're looking for. It really just has to do with how services are being billed to Medicaid.
Okay. All right. I had a second question. I just lost my train of thought. Gosh. Oh, I was gonna ask. In for Medicaid, is that one of your study examples in your appendix that you had in your PowerPoint?
So Medicaid, because it serves as the backbone, it's the population that we have most claims data for. Oftentimes that population becomes the population of all the studies that we do. So as Anise mentioned, one of the things we've really been looking at the governor's guidance is folks who suffer from opioid use disorder and what accidental overdose death rates look like, and also what enrollment in medication assisted treatment looks like. So oftentimes for those type of analyses, the underlying population is going to be Medicaid. In alignment with kind of state priorities, I think that has really resonated because the state is interested in thinking about how to connect services with those who are most vulnerable. And oftentimes most vulnerable is also defined as financially vulnerable.
Okay. All right, that makes sense. And what about, does this database also include personal information, like people with disabilities, like what kind of disabilities they have, so they can be able to understand where what the needs and where the state needs to focus on in the future?
Exactly. So what we would be able to track is on a person level, for example, the types of developmental disabilities that they've been diagnosed with. We would get that indicator through the Medicaid claims data. Or if there are also designated state programs for specific populations, we would be able to get a flag from them that says, yes, this person qualifies for this program, which means they have this disability. As mentioned, we can't release identifiers. So how that happens is when someone gives us data, they give us identifiers. We put it all together, we crunch it in, and then what we put out, as Anise had previously mentioned, is what we call an ecosystem ID or an enterprise ID. Okay. Essentially, that is completely de-identified. Brett, you would be number 1, I'd be number 2, Carol would be number 3. And what that allows you is across all the different agency data sets that we have, we could always track that person by the number, but you can't back into who that person is.
Right, no, that's great. And can you also track data attached to that same enterprise ID for that person? Like if there are different data, like God forbid they're an opioid user, you can also see that they're part of that same chain link of data?
Exactly. That's the strength of the ecosystem of what makes it really unique and powerful as an integrated data system is, for example, I would be able to see you as a proverbial you, not you, Brett. Your identity is safe with us. You know, if you engage with the hospital system and you were a Medicaid beneficiaries, we would be able to see the claims that were submitted for you. So that tells me what medical conditions you have, when you might have been hospitalized, what was the services and the costs. And then we could pull from other integrated state agency data, such as from Department of Labor and Trading, to say, for a given quarter, what did your wages look like? What did your employment look like? If you were unemployed, did you receive unemployment assistance? And so that's helpful because it really gets into a nuanced view of how each person engages with the state right now, what their needs are, and where we can really start directing limited resources to really help bring everyone up and to meet them where they are.
Okay, and the focus is mostly on people who get help through Medicare and Medicaid because that's using taxpayer dollars, as opposed to people who are on private insurance?
I would spin it in a different way, which is to say that we care about everyone, but part of what we do is limited by the data that we have. And the most robust data that we have is for the Medicaid population.
Okay, that makes sense. I appreciate that. Thank you.
Of course.
Did anybody else have any questions or observations or? Christine, it looks like you just popped up.
Just one final comment. We know that there's a large percentage of individuals in the deaf community that are Medicaid recipients. So therefore, the data ecosystem should have some robust information because they are Medicaid recipients, based on what was being said. So I just wanted to make sure I'm understanding that correctly. And we should be able to have or be able to find data or have data available based on the claims that are submitted on their behalf for the services that they may have received at hospitals or doctors' offices and so forth. Do I understand that correctly, Lisa?
That's correct. But without overpromising, I do want to do what Annie's committed to, which is let us actually take a look at the data and see how comprehensive it is. Our experience in working with other populations or other specialty areas is at times there are what are called carve-outs. This just has to do with billing to the state. So there are times in which certain services will be billed to Medicaid and therefore reflected in the claims data we get. Other times it might get bypassed and submitted for payment to a slightly different agency, in which point we wouldn't see in the data. Sure. So I think a really good next step is for us to take a look at what we have and say, are there sufficient data elements for us to start identifying these populations? And then how comprehensive does that data actually look like?
Okay, perfect, thank you.
I just want to say it's been such a pleasure chatting with everyone. And I think a really great next step would be to set up a meeting. It sounds like Christine, Ernest, Lisa, myself at least, and we can talk about what the quality of the deaf and hard of hearing data are within the Medicaid data and a potential data license request.
Oh, that's a great idea. And I really appreciate your time, Annie and Lisa, especially taking time out of your work day. And if there's any support you need from the committee in your in the commission's request to get the data license, or if there's any information you need from us, please let me know. And thank you so much. I really appreciate it. Anybody else have me one last final word and we can let them go? No.
Well, thank you so much for having us. This was a pleasure, and we look forward to continuing the conversation.
Yeah, awesome. Thank you so much. I really appreciate it. We definitely learned a lot today, and it was definitely a nice change from just doing normal update to learn more about how what some of our capabilities that our state offices are doing. So this is wonderful. I really appreciate it. Thank you.
Thank you. Have a good night.
Have a good night. Bye. And I think for the rest of us, thank you for getting through that and asking great questions. We learned a lot there. Pretty interesting and how reliable we are to this day in 2021 on data and how much information we can get out of it. And so hopefully Christine and Ernest and the rest of the project team will be able to get some valuable information working with them and hope to be able to support the project and our objectives. I think that wraps up this part of the meeting, and then we can move on to the next part of the agenda, which is progress update for the Healthcare Committee and the HSTP project. And I know Dr. Lynch wanted to also provide an update as well. Dr. Lynch, if you would like to, I'm happy to give you the ball and you can share your update.
So I can't seem to undo my video for some reason. I don't know why. All right, start my video.
Oh, I can see you now.
Oh, you can, okay. So I developed just a one pager, just a brief overview, and I just wonder if I could share that.
Yeah, go ahead. Yeah.
Yep, I will make you a co-host. Give me one moment here.
Okay, thank you.
You should be able to now.
All right.
All right, we can see it now.
Okay. So I have been working closely with Ernest and Christine, Carol Fay, Maureen McEntee, Tim Riker, and Charlie Thorne to basically what we've been doing is working on a backwards design to come up with the project goals and competencies for a public health and equity sign language interpreter program. This is designed to extend the knowledge for current interpreters in the public healthcare sector. So this brief statement is kind of the overview and may be used for marketing of that. Basically, the design or description is to include, it will be a 9-month program starting hopefully with an in-person residency on our campus in June, and with at least 5 online learning modules focused on competencies defined by stakeholders in public healthcare settings. So what we're working on now is this has been submitted to the professional studies and continuing education on our campus. And we are in the process of kind of designing the curriculum this winter into spring, finalizing the curriculum and the assessments and who the staff and faculty that will be involved as part of the grant. So because of a no-cost extension, there has been an extension to December of 2023. And so it is envisioned that 3 cohorts will be able to run 3 cohorts by the time the grant expires. The online modules are in the process of being developed. Some might be used with already established modules that come out of the Katie Center, and yet those decisions will be made in the next couple of months. But we are pretty excited that there's a definite start date or a projected one for June, and with the remaining part of the modules pretty much online after that. Because of the pandemic, we're not sure if we can be on campus or not. The hope is to have an in-person residency, a week-long set of courses that kind of launch the program and actually establish a real collegial cohort moving forward in the first realm. Are there questions about that?
Oh, when did you say what the tentative start date again?
For June of this year.
Oh, okay, okay.
Yeah.
And it would be like a 1-week class, summer class.
That's what we hope. And we had hoped to also have it in person in a residency on our campus, with people, being able to stay in dorms and experience not just a day program, but actually get to know each other in a residency format.
And the potential, it could get delayed into the fall, or would that be the following summer?
Well, I mean, so that's a question under consideration, whether or not it actually would be a virtual residency or a virtual set of classes. And so that has to be decided based on all of the factors that are, affecting us right now.
Right.
Yeah.
Well, I mean, we can be hopeful, but yeah, I do appreciate the update. It's really, it must feel good to see something on paper for you to like, okay, we have the curriculum.
Yes.
And then that step is to hopefully initiate the program. Is there by chance I can get a copy of that after the meeting?
Sure. It is in draft form, some of this draft language. So I would just appreciate not spreading it too far or too wide.
Oh, yeah. Okay. No, I would just like have a high level just summary of what
Yeah.
you saw.
Sure.
Okay. Thank you.
Yeah.
Anybody else have any questions for Dr. Lynch before we move on? All right. Well, thank you for your time.
You're welcome. Thank you.
And then, does anybody else have any project update or on the HSCP projects or anything else related to the committee that they would like to talk about? Yeah, looks like Ernest just popped up.
Yeah, I wanted to add, related to the COVID vaccines, I wanted to explain that, the vaccine is out now. And in Rhode Island, it seems that everything is not truly going according to plan. It's not really organized. So what I mean by that, it's a tough situation, but the vaccine committee already set up phase 1, 2, and 3, and 4. So, and they are right now focusing on emergency responders, frontline workers. They're just focused on that. But they definitely forgot about people with disabilities and people who work with them. So they're just focused only right now on that. They're not focusing on, there's people not focusing on the disability agencies for getting the vaccine out. And I explained to the commission that we need the vaccine too, because it's, our work is considered important. And we work with people with disabilities, and plus people with disabilities themselves are at high risk of getting COVID.
Mm-hmm.
So we needed to respond more quickly for them. But things weren't very clear. And a lot of the agencies, the vaccine committee had lists and lists of who was involved: doctors, hospital workers, well, large organizations like
United Way.
But the disability community isn't represented in any of that. And so I definitely feel that the vaccine committee just focused on that one area and they didn't give thought to the others. So I am trying to talk to them and the governor's committee on disabilities as well, a person named Bob Cooper. He was very interested in giving us a hand, and he wrote a letter to the vaccine committee and said that people in the disability field need to be represented in that disability or in the vaccine plan. And so he had already planned to write a letter, and I had planned to write a letter, to Dr. Alexander Scott. And people who work with people with disabilities should get the vaccine quicker, because as an agency we're together. But I already had written a letter to Dr. Alexander Scott about interpreters and identifying them in phase 1, but it seems that they did not take my advice. And so now they're working, we got other people together and wrote a letter about interpreters and the data and the people who and the disability people, and they need the vaccine now.
Yep.
But hopefully, those agencies, they just didn't feel like there was enough and that we were included. And so someone wrote a letter to Providence
Journal
concerns, and when we're going to be able to get that, and that the interpreters should be recognized, that people with disabilities should be recognized. So that's really why I wanted to share that with you. And now I'm working and hopeful that things will go more smoothly and more organized. But, I'm really focused on that vaccine because it's so important. And many deaf and hard of hearing people and interpreters, feel, what's next? When is it coming to us? So there's been no communication, no access for that. So I also told the people in charge of the vaccine to please communicate and put 100% accessibility. And so, we will.
Spread the word.
I'm sorry.
Because it needs to be barrier free. There should be access, and there should be no discrimination. Everyone should be treated equally, including people with disabilities. So access has to be provided. And we need certified deaf interpreters as well to make this fully accessible. We need to make workshops accessible. So access to interpreters for these things is critical, but it's tough to educate people. It's a very difficult situation right now. And I'm pushing hard because we absolutely need to get vaccines to our critical frontline workers. We need to know where they can happen, and we need satisfaction. We need better information because a lot of people don't even know whether it's safe, where to get it, and they're feeling very much lost and in the dark. So I'm working hard to improve that situation. I'm hoping it'll get better once communication access is improved and the word has gotten out. And once we have an announcement, we'll make sure that deaf people are treated equally and not having to wait until all the hearing people have been vaccinated. And then, as usual, deaf people will be last in line, because it should not be that way. It should be barrier-free, and deaf people should have equal rights to the vaccine. So I'll share the progress with this committee. This is really critical, and everyone should be involved in promoting this. I really feel that people who are disabled in general, including deaf people, are being ignored, and others keep forgetting about us, and they're going ahead without us, and that needs to stop. So I wanted you all to be aware of this. Thank you for listening.
Thank you, Ernest. Are they considering putting people with disability in any of the vaccination phase classes? Is that something you're talking about, that you try to talk to Dr. Alexander Scott's office about?
That's the thing. I really have. I mean, we're in phase 1. That's already happening. And we're trying to nudge Dr. Alexander Scott to include interpreters, to include people with disabilities, people who work in areas where there are people with disabilities. Maybe that will be happening in phase 2. But we've already testified, we've already given the information and shared our concerns. So I can't guarantee anything right now. I wish I knew. I wish I could tell you what the plan is, but I honestly don't know. It's not clear to us, but we are really hoping that we will be considered in phase 2, interpreters, group home workers, and so forth.
Is there a way your office, is there a COVID communication among the state offices where your office could reach out to, maybe not Dr. Alexander Scott's office, but a similar office that would bring it to the committee, to the vaccine phase committee? I mean, I'm trying to brainstorm if there's a way to help you get your message out to them.
Yeah, right now we're working with Karen Boucher, Mike Bear. We're working hard to do a vaccine workshop. We're going to get information out there. We're going to talk about access. We're going to hire a certified deaf interpreter to provide this information to the deaf community in that workshop. So we'll make sure that it's clearly communicated to the deaf community. That's something that we're doing right now with Rhode Island Department of Health and with Mike Bear, just to make sure communication is clear and rapid. As far as the vaccine being available and where to go to get it, and things like that, whether you need to be vaccinated once or twice, this information needs to be clarified to the deaf community. So that's what we're working on, and Mike Bear is working on this, and Carmen is working on this as well. But we still need to push hard to make sure that this happens. It needs to be ready and dispatched as soon as possible. And again, people with disabilities need to feel that they're being treated fairly, and they also need to trust the vaccine, of course.
I think Mike just joined.
Yes, Brett, hi. I wanted to just quickly add to what Ernest just said, if you don't mind. I wanted to talk about two different issues here. One of them is the vaccine being a priority and how it's prioritized. I read the CDC, that's the Center of Disease Control, their committee guidelines and what they recommend in terms of phase 1. And then there's 1A, 1B, 1C, and then 2, 2A, 2B, 2C, and so forth. And it's based on age, it's based on risk factors, health status, and they nothing to do with disability. They never even mention disability. And myself, as a deaf person, they don't even regard that. They're mostly looking at things like ethnicity, because some ethnicities have higher risks of infection than other people, or risk of death than other people. And so the CDC, and then there's the state of Rhode Island. And when you compare those two, which doctor? I don't know if it's Dr. Scott. There was a meeting last week.
Dr. Philip Chan. Dr. Philip Chan.
Oh, okay, Philip Chan. Thank you. I wasn't at the meeting, but I looked at the paper, and it looks like the CDC and the Rhode Island policies are pretty much in line with each other in terms of priority groups. I am more concerned with how the information is getting out there and information access. The information needs to be ready for the deaf and hard of hearing community. And we have I'm on a couple of committees that are very much aware that of our proposals. In the last couple of weeks, we've gotten so much information. So I feel like I do have a letter ready to go, which I'll happily share with Ernest. And that's all set. And I'll also I'd like to send that to Dr. Philip Chan and also request their support for having sign language information available regarding the vaccine. We have a couple of videos from other states that we've looked at, and we've downloaded that into the letter that we're sending to him. I'm confident that Rhode Island Department of Health will respond. I am confident. It's just, it takes time. And I'm hoping that we can clarify that they're two separate issues. Thank you, Ernest. I appreciate what you said.
No, I appreciate that. Yeah, it's a pretty sensitive topic now. Obviously, with the rollout being a little bumpy but that would to be expected with the idea of a vaccinated and mass population racing against time. But I guess my thought is something we can control right now is the messaging plan to our deaf and hard of hearing community to prepare them for when it is their turn based on the different phases that are already determined, to get them to prepare them and to educate them of their rights and what they, like when they are eligible to get vaccinated and when, where they can go do it. But I think that's something we can work on until we get more answers. And I think Carmen just popped up, so I'll let her speak.
Good evening, and thank you for the opportunity. I just wanted to thank Ernest and Mike also for the advocacy that they've been doing within the Department of Health. We did had a meeting last week. Things are moving rapidly in some areas, very slow in others, but I just want you to know that the communication access and the vaccine information, I mean, is being all is being discussed. That doesn't give you any answers right now, but I just want you to know that the Office of Special Needs, Deborah Gunnar, myself, I had been appointed now to be working with the COVID unit on the disability component of it. So I just started the job basically last week double, and then this week is my first week full time. So I'm definitely going to continue to advocate for the concerns that everyone has, especially at the beginning, starting with the access that Ernest was able to express during the meeting last Wednesday, which it was very helpful because it's always wonderful to hear it from different people. Unfortunately, that this is something that we should not be having a conversation about. And as you know, Dr. Alexander Scott is a lot into, and the team at the Department of Health is a lot of into equity and making sure that everyone have equal access. So this is quick. One of the barriers that we have in with immunizations is that the state is not getting the amounts that they were, quote, supposed to be getting. So it's like plans are, you know, they're trying to, like someone mentioned, follow the CDC guidelines, but those were things that were put in there. But I look forward to the continued partnership with everyone, and we really appreciate everyone's collaboration and bringing forward what the concerns are. So we tomorrow morning I have a meeting scheduled with the Gunnars where we're going to be continuing to discuss the next steps. So I will keep informed with Mike. We sent out one of the workshops that we have scheduled for tomorrow. And thank you, Mike and Ernest, for having the translators, interpreters there for that workshop. That would be very helpful because also that sets up the tone of how we are going to partner to get the information at the same time. So I appreciate your collaboration and the partnership that we continue to have. Thank you.
This is Mike. Brett, is it okay if I make a comment? I had a question for Carmen.
Sure, go ahead.
Okay. Okay. Hi, Carmen. Very nice to see you. And yeah, I noticed that you have a different job title. When you responded to my email on Monday morning, I was thrilled to see that you are now much more involved with the disability community. So I know you're a great advocate. You always have been, and I know you will continue to be. My first question for you, Carmen, is I haven't had a chance to be involved with all the different disability groups but I'm trying to understand exactly how a person with a disability who might be very healthy, but maybe they feel that they're not being considered for the vaccine at an earlier time. I don't know. I'm using myself as an example. I'm just thinking of myself. I'm a white male, I'm in my 50s, I'm very healthy, and according to recommended guidelines, I wasn't expecting a vaccine until this summer, to be honest with you. And then I look at people who are ahead of me in line. It makes sense to me completely. So I know I have to wait to be eligible for the vaccine, but I'm trying to understand from the disability community point of view how they feel. They feel that they've been neglected. I'm trying to understand that better. I don't know if, Carmen, you have an answer to that or insight into that.
Yeah.
If you could help me understand what's the bigger picture here, especially coming from Bob Cooper, that I'm curious what the issue is. And I'm not talking about deaf and hard of hearing per se. I know communication access is a unique issue, and that's something that we continue to work on. But in terms of disability in general, why do people feel that they're not part of the decision-making process and the priorities for the vaccine? And maybe I'm changing the subject or missing the point here, but I wonder if you could follow where I'm going with this and come up with an answer for me.
I'm going to try to provide you with some information. However, I do not want to speak on behalf of the vaccine subcommittee. So I want to be clear on that. Based on the meeting that we had last Wednesday on January 6th, what people expressed was that they were not feeling that they were part of the decision making, since a lot of them felt that there was no representation on the vaccine subcommittee. So I think that is the major concern right now when it comes to the vaccination priorities. So that was my understanding from the meeting. I actually have been working directly at the COVID unit in different sections, so I was not totally following all the areas that's being discussed. However, with the new job post, new position that I just got, and it's just a 1-year position, my main focus is going to be how is the disability community doing? Not what the perception is how are people doing? Because we all have different perceptions of how we're doing, right? How we do our job, how we do the service that we have. But within the next year, as soon as I was hired for the position, that's how I scheduled that meeting on Wednesday, just to have a complete, or at least an umbrella overview of where we are, and then what do we need to do to go forward. So a lot of people have been working, trying to make sure that everyone is included. But as you have said, the Rhode Island is following the guidelines that the CDC put together. So I think that's where a lot of the concerns have been, because all the states have decided not to follow the CDC and just do whatever else. We are following CDC guidelines. So I think that one of the concerns where people are a little bit disagreeing. I don't know if that answers your question, but in the disability component of it, we're definitely going to work.
Yeah, thank you. Yeah, that's something we could probably talk about all night, but I don't want to take up the time of the committee. It's just something I'm looking forward to working with you, Carmen, and talking more with you about this issue over the next couple weeks. This is Ernest. I would like to add people in the disabled community, they need to hear about information because they're dying at a much higher rate than people who are not disabled. People who are not disabled are people who are disabled are at a very high risk, much more so than people with disabilities. So folks with disabilities are at a much higher risk of death than people who are not disabled. And so they should be prioritized because we are high risk, not only minorities, but also health disparities, people who are blind, people who have, people don't know where to turn, what to read, where to get information. And I feel they need to be moved up on the list so they have a sense of fairness, because our health is just as important as anyone else's health. I may be healthy, but someone in my community may not be. And so, and again, disabled people are left out of the healthcare system typically, and they're at a much higher risk. So they feel like something needs to be done for equity. Hopefully that was helpful to you, Mike. Thank you.
All right. Thank you both. And thank you, Carmen, for your input. Really appreciate it. Obviously, vaccination is a very big topic for the next half year, at least. So more to come on that. I want to use the last 20 minutes to make sure that if we have any project update that we want to touch upon for the HSTP projects, or if anybody had any topic they want to plan for the next meeting. And looks like Christine just popped up. So Christine, do you want to go ahead?
Sure. Thanks, Brett. So just a brief update, and Alex, please feel free to join me anytime. I just want to let you know that we did submit the no-cost extension request to EOHHS, and it was approved. So we are official in continuing with the HSTP grant throughout 2021. So we're excited about that. As you know, both Alex and I will be staying on. Lindsay and Thomas have moved on to other positions, but I do want to thank them for all their time and all their work that they put into this project in 2020. You already heard from Dr. Lynch, from Marie. She spoke about the interpreting program at RIC, and I just want to say, while she's still here, that both she and the folks at RIC have been fantastic partners throughout this process. And I can't thank her enough for all the work that she's done so far on the interpreting program. So that leaves project goal number 1 and project goal number 2 for both Alex and I to finish up over the course of the year. And our focus will be taking the results of the 2 surveys and analyzing the results, converting that information into visual format, and of course, completing the project deliverable, which is the consolidated final report for the community. So we'll be focusing our attention on that. And also the virtual trainings as a part of project goal number 2 with the healthcare professionals. So again, we're taking the results of that survey for healthcare professionals, and we're designing trainings to meet some of those knowledge gaps. And we've already been in communication with some of the content experts out in the community who we've solicited to provide those trainings. And Alex will be doing a fantastic job, I'm sure, in taking those trainings and editing them and making them available for the public and for the website. Speaking of the website, it is still being constructed by the state. It's fully designed with a prototype. It's just a matter of changing it to the state system. So that's currently in process. And I think that's about it for now. We do have a little more time built into this year to achieve these project deliverables. I know last year we were kind of going at a lightning speed because we weren't sure about whether or not the grant was going to be extended for another year. But we do have a little bit of cushion and a little bit of time to be able to carry out the rest of these project deliverables. Most of our time will be focused on the interpreting program because that, as Dr. Lynch mentioned, should be launching in June if all goes well. So in terms of our work, I look forward to continuing working with Alex on the project and with this healthcare committee and moving forward with it. Both Marie and I have been in discussion with some other folks at RIC on a proposal for the Department of Labor and Training, and we should have more information about that in the upcoming months. I certainly don't foresee the need to meet on a monthly basis because we have a little bit more cushion in terms of time. But if this is something that the Healthcare Committee would like to continue doing, meeting on a monthly basis, especially in terms of COVID and the recent discussion that was just had with Ernest and Mike and Carmen, perhaps it's worth meeting on a monthly basis. But I know for HSTP, if that's not something that's necessary, and I don't foresee that it is, we can hold off on meeting every other month, or we can continue to report out on a monthly basis if you folks decide to continue to have that cadence for meetings. Alex, did you want to add anything?
I just know Mike was interested in hearing about data, and we are collecting that and analyzing it right now. I know I mentioned last meeting that I'm like strangely excited to get into this data to see where the gaps and weaknesses are. Where there are a lot of things that we already know of, namely a lot of healthcare providers don't even know about the commission, which is a huge, big, glaring problem. But I want to see a lot of the granular data as well too, from the deaf community and then from healthcare providers, and that is what we're going to focus in on with our training modules. Is the data will dictate what we will focus on editing and presenting and making into training modules. So that's our work cut out ahead of us.
Thank you, Alex, and thank you, Christine. So the no cost extension were approved to how long?
Mike is.
Oh,
sorry, Mike just had.
sorry. Oh, I apologize. Go ahead.
Christine West, maybe I overlooked it, but will we receive a summary of the data results? I'm really curious to read them because I'm sure there's so much related to my department and communication access and things like that. So are you when you're going to be writing something, or you haven't written it yet, or I guess maybe I'll just wait a few more weeks. Okay, sorry, Christine.
Sure. Originally, the communication I had with Gallaudet, as you know, Gallaudet is the one who designed the survey, and they're tallying the results. Originally, the agreement was the survey for the deaf and hard of hearing community was to be completed on December 14th, with the results provided on December 18th. We got to December 14th, and we were all pretty happy with the amount of participation that we had been generating. And by the way, I just have to thank the commission staff for everyone's involvement in really pushing out that survey over the last couple of weeks. The numbers kept going up and up. So the decision was, instead of stopping on December 14th, is extending that survey until the end of the week, which is December 18th. So we concluded the survey on December 18th. At that time, there was a break at Gallaudet, and so I have not received the results yet. Folks are just getting back into the swing of things. So I have been in communication with them via email. So I am expecting to hear back from them within the next week. And certainly their invoice won't be paid until we get the results. So I'm sure those results will be coming soon.
Okay, great. Thank you. Yeah, no rush. I was just curious.
Me too.
So you said that the results haven't come yet, is what I understand.
That is correct. We do not have the results of the deaf and hard of hearing survey yet, but we do expect it shortly.
Okay. All right. Thank you. And I wanted to ask, how long is the no cost extension approved for?
It's actually approved for the full year. So the no cost extension goes to December of 2021. So we do have another full year of working if necessary. It's possible that we can achieve those project deliverables before that time. However, we do have it in the budget that we have until technically 2023, to be honest with you. We have a budget that will allow for us to continue to 2021. But if those funds are not used by the end of 2021, then certainly we can keep going until we complete our project deliverables and as long as funding remains.
Okay.
I do just want to go back to the surveys. I did forget to mention that Gallaudet did inform me that of the number of participants we had for the survey. And the total number of participants for part A, the first part, was 130 people. They had originally had 135, but there were some responses that were not valid for a variety of reasons. And so the actual number of completed responses for part A was 130, which is a fantastic number. Our goal was 200. We got 130. That was great. I think it's probably the largest number that we've received for a health survey in the state for this community. And then for part B, we had 101 individuals participate. So I personally am really happy with those numbers, and we'll see the breakdown in the results of the data once they send it later this month.
That's great. Wonderful. Yeah. I had another question. I can't remember. No cost. Oh, I just want to thank you for that, for your work on the no cost extension, especially I know you were trying to cram it last minute in December, and among other things, I really appreciate your effort on it. Thank you so much. And I also want to thank Lindsay. I know she's still here in the meeting. I want to thank you for all your effort on the project team. Christine spoke very highly of you and the work you've done. And we are very much appreciated. And we have no doubt you're going to continue to do great things in where you go. And thank you so much. And Alex, really appreciate your effort and your passion into the data. God bless you, because data is something either you really love or you really hate. So I really appreciate it. And I'm fine with Christine's suggestion on the meeting cadence. If there's any other people you can think of that you want to come into the meeting to talk, like we had Anish and Lisa today, please let me know. And maybe depending on how the vaccination conversations go between Ernest and Carmen, please get in touch with me if you want to have another healthcare committee meeting. I mean, most of the scope of the committee had been supporting the HSTP project. So if there's a new scope we need to focus on, I'm open to ideas. So let me know. Otherwise, I don't know if it's something more for the monthly commission meeting that we have, because this is more of a major issue rather than just healthcare committee. I mean, we can get more outreach at the commission meeting level. But other than that, is there anything we need more support on, or any feedback?
No.
No?
So far, so good. Thank you, Brett, for all your leadership and for the great job you're doing with these meetings. Appreciate it.
No, I appreciate it. Can't do it without you guys, especially you, Christine, leading the project team. Yeah, I thought it was very insightful today with Anis and Lisa today. Just really understanding how they apply the data, and it's a pretty powerful tool. And in this day and age, in the digital age, it's just going to continue to grow. And hopefully we can get leverage the ecosystem for more deaf and hard of hearing data, especially knowing that a lot of our community Medicaid patients. If there's nothing else with that said, I think I will wrap up the meeting 5 minutes earlier. You get 5 minutes of your day back. I will check in with you guys probably the end of the month to schedule a meeting for maybe end of February or early March. And kind of like a 6-week time frame. And until then, stay safe, stay warm, hang in there, and Happy New Year, everybody.
Thank you.
All right, thank you. And Bethany, can I just get a copy of the